I would, I think again, Dr. Ramamurthy needs no introduction. Is the chairman and managing director of the Eye Foundation Group of Hospitals. Again, a very versatile cataract refractive surgeon and past president. So on to you.
Topoguided
I'm
treatment.
Extremely unhappy about this, but I want both of you to talk. So
this is how you treat past presidents.
okay, then we'll have more time. I request give us 6 more minutes. Come.
The Topoguided treatment has been introduced as a repair tool way back in 2003. Here we are more concerned about the best corrected visual acuity rather than the uncorrected visual acuity. I'll straight away go on to some of the examples. One of the major advantages of Topoguided treatment is a bimodal treatment where you are not only flattening the steep part of the cornea but also steepening the flat part of the cornea. The basic principle is where you don't use beyond 50 microns of corneal tissue, and usually always we do it along with the cross-linking so that whatever effect we achieve is retained for the patient. And if there is mild irregularity and a small power that needs to be corrected, maybe both wavefront guided as well as topoguided ablation will work. But if it's a large error that needs to be corrected, topoguided ablation is the way to go. I'll quickly run through some cases. It's a minus 5.25 with a 0.5 diopters intralace treatment done way back in 2009. Patient achieved 6/6 vision, but complained of persistent glare and night vision difficulty. This is the pre-op topography, and this is what you see post-operatively. You can see an area of flattening over here, and that's impinging on the central 3 millimeters also, and that is the reason the patient was having dysphotopsia symptoms. So what we essentially do in this situation is to go ahead and do a topoguided treatment, and you find that excellent flattening has been achieved, and you find that this was the pre-operative picture and this is the post-operative picture, and you find that from 37.1 is 39.2, and the difference between the superior part and the inferior part has largely gone away, and you can see a sea of yellow, because of which the patient's symptoms are significantly diminished. Going on to a case number 2 where we had a epithelial ingrowth, the epithelial debridement was done, but there was significant flattening in that area. That's the reason that you find the significant flattening over here, and which is also going on to the central 3 millimeters, because of which the patient not only had a astigmatism but also poor quality of vision. So topoguided treatment was what was done. You can see this bimodal treatment very nicely represented here. In the steeper area, in the flatter area, steeper area we're flattening it, while outside of the steep area we're putting in some laser treatment so as to steepen this area. And this is what we achieved at the end of the treatment. And this is the comparison maps. This is the preoperative treatment, preoperative map. This is the actual treatment profile, where you see that the flatter area has been, the steeper area has been flattened, and outside of the flat area, we do a little bit of laser ablation to steepen this area. And what you find is that from a 35.1 over here, it has come to 39.8, which almost matches the 39. That's the reason that even though the patient requires a certain amount of myopic astigmatic correction, the quality of vision is excellent, and the patient actually preferred not to do any further treatment. Case 3 is again a optics treatment done way back. In this case, we had a low hinge, because of which not only there was a requirement for glasses, but poor quality of vision. Here again, what you find is significant flattening in this area because of the double ablation that has happened over here, and the residual refractive error. Is not just the requirement of glasses, but the poor quality of vision that these patients complain of. Subsequent to a TCAT treatment, this will become better represented over here. You can see this is the pre-treatment topography. You can see a significant flattening over here. This is post-treatment, where you see, especially in the central 3 millimeters, almost exactly the same amount of 40.3 is what you have in the inferior half and the superior half, because of which not only the refractive error came down, but the quality of the patient that the patient had also significantly improved. And here again, there is a microkeratome LASIK that was done, because we had a free flap. The patient had a significant area of steepening here because of the flap had not been properly positioned, not only requirement for glasses, poor quality of vision. So again, a similar treatment. And here, subsequent to the initial TCAT topography, what we achieved was a significant residual refractive error, though the quality of vision improved. So the patient, since significant adequate amount of tissue was left over, we went ahead and did a second treatment which was a wavefront optimized treatment to address the refractive error. And then this resulted in a picture like this. So these are 3 comparative maps that you can see. This is immediately soon after the free flap. You can see a very irregular cornea over here. And then subsequently 3 months later, when we did a post-ECAT, we could reduce it to 48.5. But since still a significant amount of refractive error was there, finally when we did a wavefront optimized treatment, we could not only take care of the irregularity which was done by the first step treatment, but with the second step treatment, we could also take care of the refractive error, so that we ended up with a very small astigmatism and a very satisfied patient.
I think we could conclude.
Okay, I can. Thank
Sorry.
you.
Very sorry.